Hey, good afternoon, everybody. We'll get started in a couple of minutes and get this going. Just a reminder, if you're not speaking, to please mute your microphones. All right, can everybody hear me okay? We're going to go ahead and get started this afternoon. Give me just 1 second to get everything pulled up. All right. All right, so good afternoon, everyone. This is our November maternal webinar series. Thanks for joining us this November. The title for today's presentation is Quantification versus Estimation in Obstetrical Blood Loss. Before we get started, just a quick reminder to mute your lines during the webinar to avoid any interruptions. This webinar and past webinars are housed on the GAP-QC website for review at your convenience. They're located under the Maternal tab, and they're also available on the Department of Public Health's YouTube channel. We should have a few minutes for questions at the end of the presentation. Feel free to type any questions into the chat. If for some reason we do run out of time and you have a question, you can email that to gapqc@dph.ga.gov, and we will get back to you. Our next GAP-QC maternal webinar is scheduled for Tuesday, November the 5th at 2 p.m. Simple QI, our new data platform, is up and running. If you're having any issues accessing the site, creating your homepage, or assigning roles, please let Jennifer Boland know as soon as possible. Jennifer is our improvement advisor. She also does your coaching and technical assistance, so use Jennifer as a resource. Our FY24 quarter 3 data submission for July through September was due last week on October the 31st. Please sign in to SQI and submit your data. We love to get that, and some data is always better than none. You can also go in and submit back data into this new data platform as well. We're looking at potentially moving our hypertension into sustainability in the spring of this year. Planning's underway for that transition. You will still be able to submit and track data in the SQI data platform. We will be having more information as we complete this transition into sustainability over the next few months. We are actively planning for next year's annual conference. It's scheduled for April the 24th and the 25th. It will be held at the Emory Conference Center again this year. And we do have a save the date. And I'll show that to you in just one second. There is our save the date for that. And I have been sending that out and will continue to send that out. Please share that with anyone who may be interested or you think will benefit from attending that conference. We recently provided 100 seats to the Institute for Perinatal Quality Improvement Birth Equity modules. If you accepted the modules using the promo code, please complete all 4 of those modules as soon as possible. Once all the modules are completed, you will receive CNE credits. Completion of the health equity modules will improve your facility's commitment to AIM's 5th R, which is the respectful, equitable, and supportive care. So you can also record that as education to your staff and to yourself. We're actively recruiting new facilities for our Wave 3 to participate in the Cardiac Conditions and Obstetrical Care Patient Safety Bundle. Wave 3 will start in January of 2025. Use the QR code on the screen if you want to get registered. Just a reminder, we do have 2 options for that. We have the learning as well as the active cohort. If your facility is interested and would like more information, I'm happy to jump on a call with you guys. Feel free to reach out to me. You can email me at amy.mock, M-O-C-K, @dph.ga.gov. Just some upcoming resources, opportunities that I wanted to share with you guys. These are the AIM Data Lunch and Learns that are coming up. They'll occur every other month starting in January of 2025. These sessions will focus on various data-related topics, and they're listed there for you to view. As these come available, of course, I will send out more information about those and the registration that goes along with those. Mama's Voices and AIM Community of Learning Cohort 4 for hospitals will begin in February of 2025. If your facility is working to address the respectful, equitable, and supportive care as part of your quality improvement work, this is a great opportunity with excellent resources that go along with it. The community of learning incorporates people with lived experience and ways to effectively build a patient engagement culture and perform work that integrates patients and their support systems into perinatal work. For more information or to secure a spot, you can use the QR code that's on the screen here, or you can go to www.mamasvoices.org. And the next OPS workshop, hosted by Hope for Georgia Moms, North Georgia Health Center's Center for Simulation and Innovation, that's a mouthful, and A1 will be in December of this year. Additionally, they've extended and added other classes through the end of 2025. These classes provide skills in managing OB emergencies through simulation and debriefing. If you're interested in being a part of any of these classes, contact Tasha at the email address on the screen. And last slide before I introduce our speaker, our maternal cardiac conditions key driver diagram. As always, we like to review the goal, which is to reduce severe morbidity, mortality related to maternal cardiac conditions in Georgia. Our SMART aim is to, by February the 6th, 2026, which is known as National Go Red Day, to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%. Of course, we follow the 5 R's based on AIM, and within those 5 R's, we have our structure and process measures. So today, I'd like to introduce our guest speaker. Please help me give a warm welcome to Dr. Christy Gable. Dr. Gable began her perinatal nursing career in 1989. She has experience in labor and delivery, postpartum, newborn, and NICU. She served as clinical nurse specialist in a variety of roles and settings. Dr. Gable was appointed to the California Maternal Mortality Review Committee and co-authored several toolkits on obstetric hemorrhage and hypertensive disorders of pregnancy. Dr. Gable recently retired from clinical work, but remains very active in A1, where she will serve as the Missouri section chair next year. Dr. Gable will speak to us today again about quantification versus estimation in obstetrical blood loss. So I'll turn it over to you, Dr. Gable.
Hi, everyone. Thanks for having me. I appreciate the invite. And I'm going to share my screen here. And can you see that okay?
Yes.
Okay. All right. So
we're seeing, Dr. Gable, I'm sorry to interrupt. We're seeing all the different participants.
Stop sharing. Let's see how I do that then. It worked earlier.
Yep.
Choose what we wanted to do. Chrome, window, entire screen. About that one.
That's it. Yes, ma'am.
Okay.
Thank you.
You're welcome. Okay, so just to get started here, these are the learning objectives that I have for today that will define hemorrhage and list the terms and techniques to describe blood loss. List 2 reasons quantification is better than estimation, and describe the differences between the methods that we use for measuring blood loss. Let's do it that way. Okay. This was a study that was done in 1967, long time ago, and by Brandt. He looked at the difficulties and importance of precise estimation of postpartum hemorrhage. He compared measured with estimated blood loss and found that with small amounts, the results were essentially equal. But as the amount of loss increased, so does our underestimation of that loss. And this was a quote that, or a statement that he made in the introduction of the study that I really liked. And even back in 1967, because of the failure to recognize the extent of hemorrhage, its true importance in morbidity and mortality tends to be missed. I'm not showing. Is that better?
Yes, that's perfect. Thank you.
Okay. Sorry, I was not in presentation mode there. So we have a call to action that's been made for quantifying blood loss that will address maternal morbidity from hemorrhage. It's now a practice that's recommended by ACOG and A1, Joint Commission, and now the hot off the press, and I'll share that with you later, CMS is getting involved. So all for patient safety. So in looking at some of the statistics, looking at some of these statistics, this is a slide that was from the National Center for Health Statistics, the National Vital Statistics System, and it shows that there's a statistically significant increase from previous years, from 2018 to 2021, for all. The total went from 17.4 to 32.9, and you can see the rates there for non-Hispanic Black, non-Hispanic White, and Hispanic all have seen an increase in previous years. This was also a slide or some data on age groups, and again, statistically significant increase from previous years. When I looked at your mortality report, this was the leading causes of pregnancy-related deaths, and you had 16 for hemorrhage, and about almost 85% of these pregnancy-related deaths were determined to be preventable. So we have work to do that we can do that will help prevent some of these deaths from hemorrhage. These are your maternal goals for your perinatal quality collaborative, and I won't go into a whole lot of that, but basically that quantifying blood loss of 100% of women who had blood loss measurement from birth should be documented in your records, and that we should be doing these for every delivery. This was information on your SMM rates, and if you look at the lime green one at the top, has decreased from 31.5 to 28.6, pretty good for all hemorrhage. And then the blue line, I think it's the blue line, purple line, this one also has, and that's those hemorrhage cases that you excluded hemorrhage transfusion, has also declined, which is good. Excuse me. So I'm looking at California data, which is where I'm from. I moved to Missouri a couple of years ago now, but I did a lot of work in California for 20 years prior to my retirement, that with perinatal quality improvement, not only as a clinical nurse specialist, but I managed a regional perinatal program in California for public health. And so I was a part of the mortality review committee, and this was our first report report that came out in 2021. The first report was in 2015, I think. Anyway, showing that California in 2005, which was kind of the driving force for the state to kind of start looking at mortality ratios, because it went from 11.7 to 16.9 there in just a year's time. So CMQCC was founded in 2006 at Stanford Medicine, and together with the state of California, wanted to respond to these rising mortality and morbidity rates. The California Maternal Quality Care Collaborative, CMQCC, has seen a decline by 65% between 2006 and 2017 or 16, while the national mortality rate has continued to rise. From the mortality review committee that we worked on, the first the low-hanging fruit was the OB hemorrhage or hemorrhage rates that we felt we could make a difference on, and so that toolkit was published in 2010. And so you can see we were already on the decline before that, but we had already started work on some of that before the toolkit actually came out. And since then, there's been 2 more iterations of it. So the latest was in 2022. So here's based on that review from the mortality review, we looked at those cases 2002 to 2007, and these were the factors that contributed to those deaths. And delaying response to clinical warning signs and ineffective care was 3/4 of the cases, with misdiagnosis as 33%. So when we define hemorrhage, historically, estimated blood loss more than 500 mils after a vaginal birth and more than 1,000 mils after C-section births were widely used to define postpartum hemorrhage. But these estimates tended to underestimate blood loss. So ACOG nomenclature consensus conference called the Revitalize conference revised the definition above to include the greater than or cumulative blood loss greater than or equal to 1,000 mils for either vaginal or cesarean birth, or a blood loss accompanied by signs and symptoms of hypovolemia within 24 hours after birth. And then a greater than or equal to 500 mils in the vaginal birth is considered abnormal and should warrant further investigation to address the cause. A cumulative assessment is a critical component of any safety bundle that we have. So I'm looking at all the different terms now that we have, terms and techniques of describing blood loss. We have estimated blood loss, and it's been just an eyeball kind of thing at the whatever you're using. Mostly was the buttocks drapes that weren't calibrated. It was just a little clear plastic container that for all of the loss from delivery to be under. Not always accurate, as we know, and I'll get into that in a minute. We have QBL, and there's 3 different ways now to do that. There's gravimetric, which is just weighing everything that you have, sponges, gauze, you can weigh sheets and towels and things like that. There's also the volumetric method, which is looking at all of the blood that you have in your canisters for in the operating room, and subtracting volumes that are like amniotic fluid and irrigation. And there's methods to do that. And then the more recent one is the colorimetric, which is a device that scans any of the materials that you have in the OR. And because of artificial intelligence, it has a calculation of how much of like red blood cells that they look at. It's kind of a neat little thing. I happened to see that we before I left Sutter in California, that we trialed those, and they're a little expensive, so we didn't go with that, but that's on the way, and I'm sure that as more companies get involved, they'll come down on those prices. And then we look at CBL, which is cumulative blood loss, which is the ongoing blood loss that's determined by adding all of the ways that the gravimetric, volumetric, colorimetric, whatever ones you're using, into one number that is then communicated routinely throughout your case, just to let everybody be aware of what's going on in the room, kind of that shared mental model that we need and strive for. Okay, so this was something that came from CMQCC. It was their slide deck for this latest iteration of the toolkit for OB hemorrhage, and just did some rationale for routine quantification of blood loss, with delay in diagnosing being the most significant factor in patients being at higher risk. QBL performed only in severe cases. If it's only performed, then staff are not familiar with the procedures and less likely to have valid data. It removes disagreement if everybody in the room is on the same page, it's done for every delivery, and everybody's in agreement that, you know, the nurses, it's a nurse-led process, and that she's communicating all of that out, things are getting weighed correctly, that everybody in the room will know that that's the way it's always done, and that number, that cumulative blood loss number, is believed. Okay, so what is our why? We know that that QBL is part of the OB hemorrhage bundle. If it's not, it should be in your facilities. And in 2015, ACOG published a consensus statement titled the National Partnership for Maternal Safety Consensus Bundle on OB Hemorrhage. Excuse me. It was a multidisciplinary work group that formulated critical care practices that were evidence-based to be implemented in all maternity care hospitals. They were organized into the 4 domains that we have now: the readiness, recognition, response, and reporting. And the 5th R has been added just recently. But each hospital, whether they're low resource or have high resources, must strive for the most accurate measurement for all patients at every delivery. So Sechrist and others took information from the California Pregnancy Associated Mortality Review report that we did and analyzed any quality improvement opportunities. They were coded and thematically organized into 3 of the 4 domains. So the readiness, recognition, and response were the 3 of the 4 R's that they looked at. One of the themes under recognition was missed signs and symptoms when blood loss before arrival and during hospitalization was underestimated. So the recommendations were to establish methods for assessing quantification and cumulative blood loss. And then QBL as a component of a bundle was shown to reduce severe maternal morbidity. And these were the studies that were done. And Shields, Larry Shields from California, worked with his team in looking at a multi-state quality improvement project for OB hemorrhage that showed a 20.8% versus a 1.2% reduction in severe maternal morbidity mortality in hospitals that were utilizing those bundles, which is pretty impressive. Okay, so when we look at the 5 R's now, and you guys have already looks like it's in all of your PQC information for each of your initiatives that you're using, that the readiness, which is every facility, making sure you have all the supplies you need, you have access to the medications, the massive transfusion policy or protocol, your how do you get your blood released quickly, running drills and simulations, is helpful for that readiness piece of it. The practice makes perfect for your facilities. The recognition and prevention, which is where I'm focused on right now today, is your assessment, diagnosis, and classification, which is your risk assessment that you're doing, hopefully on every patient that walks in the door. You know, you're coding them as a risk for hemorrhage. And then looking at your measurement of quantitative cumulative blood loss and how we do that. The response is every hemorrhage, so that you are doing this for every patient and during every delivery. Your reporting and systems learning is every unit, so that you're doing debriefs and huddles and talking about all of this stuff. You're looking at reviews for all of the cases that you have on OB hemorrhage, so that lessons can be learned. You have quality improvement measures. You're looking at response times. You're looking at types of medications that were used. And then your documentation coding. And then the last is the more recent, and it's respectful, equitable, and supportive care with every unit, provider, and team member, so that you're involving the patient and their families during their huddles and debriefs that you have at the bedside. So we'll get into some of the recommendations from the big entities that have come out in the past few years. So ACOG, this is their committee opinion number 794 on quantitative blood loss in OB hemorrhage. It came out in 2019. They're stating and recommending that because QBL is more accurate than visual, visual tends to underestimate when high volumes and overestimates when there's low. Implementation includes direct measurement and protocols for collecting and reporting that cumulative blood loss that are policies and procedures or protocols involve the multidisciplinary team, so that anesthesia is involved, the blood bank is involved, lab is involved. All of those pieces need to come together into your protocol. And then lastly, to implement that OB hemorrhage bundle. Okay. A1 has also come out with their practice brief number 13 in 2021 on quantifying blood loss. And so QBL increases your escalation of care. QBL is objective, not subjective. It reduces inaccuracies. It can decrease your additional interventions like the uterotonics, unnecessary procedures, any blood transfusions, any of those kinds of things. It helps to reduce those kinds of things and increases your team awareness as you communicate that blood loss during each case. California Maternal Quality Care Collaborative use the standard clinical definition. These are their recommendations. Implement QBL at all deliveries so that scales are in the rooms or available to you. You may not have them in every room. You can use the baby scales if you need to, if that's something you already have. The under-buttocks calibrated drapes are recommended, weighing all blood-soaked materials and weighing and measuring amounts in the OR using the canisters and lap sponge holders. To also implement standardized protocols and safety bundles, so you're monitoring for those clinical triggers like vital sign changes, increase in heart rate, respiratory rate. There's mention of looking at the shock index of greater than 0.9, and there's a calculation for that. And then to include training for all of this, as I said earlier, practice, practice, practice. So doing your drills and simulations will help you be prepared. Joint Commission now, part of the requirements, the elements of performance that became effective July 1 of 2020 were to have in place evidence-based procedures for managing a hemorrhage that includes identification of hemorrhage. It doesn't say how to do it, just that you must have one in place, and that as the evidence shows, quantifying blood loss is the most accurate, and it would make sense that this would be part of your process in identifying those patients. So also, this just came hot off the press. Was released on November 1st, a press release. I just got it yesterday, so I'll send an updated slide with this in it. But it's their first ever maternal health and safety standards for hospitals for CMS. It's committed to addressing the nation's maternity care crisis. So hospitals must meet the maternal health conditions to avoid termination from Medicare and Medicaid. This is huge. This is all about reimbursement for your hospitals. They're going to start implementing this in 2026, and they're going to phase it over a 2-year period. It'll have 3 different phases. And so among the new requirements are that each obstetric services will be well organized and in line with nationally recognized standards of care or healthcare, which means this staffing ratios, they'll need to be up with what the national standards are. Your supervision for your units will need to be by trained individuals, such as your experienced nurse, nurse practitioner, nurse midwife, a physician, and that basic equipment should be kept at the facility, readily available with respect to the facility's scope, volume, and complexity. Facilities should have provisions and protocols for emergencies, complications, and post-delivery care that are consistent with nationally recognized and evidence-based guidelines, which I've just mentioned. Joint Commission, ACOG, A1, all have, and CMQCC have evidence-based guidelines that that you will be held accountable to for CMS. Requirements for staff training, that you develop and ensure that all of your staff have been trained on your policies and procedures that improve your maternity care, and that training and documentation will need to be documented and reviewed every 2 years. Your hospitals will use findings from your quality assurance and performance improvement programs, so you'll need to have QI programs in place for that. Looking at improvement with that and analyzing the data. Emergency services for hospitals to have the adequate provisions and protocols, and you'll have emergency equipment on site, and that you have provisions set aside for those obstetric emergencies in your emergency departments. And then requirements for transfer protocols, that you have policies and procedures for obstetric patient transfer, and that all relevant staff need to be trained on those transfer protocols. So there you have it. Yikes. All right, so we're going to get into, let's see, there we go, visual estimation. So there have been some studies, and I'll just quickly go through these. Al-Qadri in 2011 showed, this was done in Arabia between 2009, 1st of November 2009 to, so they only did it for a couple of months, but they looked at a prospective cohort study. And what they found was that there was a significant difference between calculated blood loss and estimation. They tended to underestimate that loss by about 30%. This next study is the study by Larson, and they looked at visual estimation for 29 C-sections and 26 vaginal deliveries, and they compared that to the extraction of hemoglobin using the alkaline hematin method. And their conclusions were that blood loss was overestimated in cesarean, and the standard procedure of estimation was found to be unreliable. When we look at Patel and others, they looked at comparing visual using the drape with a measurement of blood loss by photospectrometry. And they results there that they visually estimate blood loss was 33% less than the drape estimate. So the measurement in the drape, they underestimated that by was 33% less. So then we look at these other studies here were done a little bit earlier in 2004, 2006, that all of these showed a significant underestimation of large volume blood loss by 33 to 50% when compared to direct measurement. So this was a study by Blosser, Smith, and Poole in 21 that looked at QBL and how it improved detection of postpartum hemorrhage. They did a retrospective of observational of deliveries before and after they changed from estimated blood loss to quantifying blood loss. The QBL outperformed EBL for predicting blood transfusions for both CD and vaginal deliveries. It's a more sensitive test, and it led to earlier recognition of hemorrhage and intervention. This was a study by Lert Bonafong, if I'm saying that correctly. I think it was the Philippines in 2016, and they looked at term low-risk vaginal deliveries, and they compared a visual estimate with the quantified amount that was in the underbuttock drapes after the infant was delivered. There was a significant difference in the EBL versus QBL, so that visuals inaccurate. It tended to underestimate, and so QBL is recommended. So when we look at this is also CMQCC slide, give them credit, that cumulative blood loss should not be used in isolation to confirm or rule out OB hemorrhage. It is just a tool. We have to look at all the other things that we look at, like vital sign changes. And we know that vital sign changes in a healthy pregnant woman are late signs. So that's why how important QBL is to putting that piece together. If you already know that you're behind the 8 ball here with more blood loss than you should have, then that's concerning, and so you need to be active, intervening more quickly. This is a little video clip. You can watch it on YouTube, and it's A1's quantification of blood loss. It's about a 3-minute video, and we tried playing it before I got on here, and it'll play, but you can't hear it. So I'll send the link to Amy so that she can send it out to you if you haven't already seen it. It's a pretty good little short snippet of what quantification of blood loss looks like for every birth. Okay, so now we get into some of the ways that we can weigh and measure. Gravimetry and volumetry are ways to measure, and so we're looking at weighing all your blood-soaked materials. You need dry weights for subtracting, and this is difficult to calculate blood loss on the floor or your clothing unless you're taking your clothing off to weigh it, or you're mopping up the floor with blood with towels and things like that, which is possible. You could do it that way if you so choose. And then volume is looking at your calibrated underbuttocks drapes and measuring before and after the birth, and I'll get into that in a minute. And using those suction canisters for cesarean deliveries. And if you do both of these together, it's considered standard, the gold standard method of getting your quantified blood loss amount. So QBL for vaginal delivery, you want to list your dry weights, and there's lots of ways to do that. There's laminated cards that you can make with every material that you could think of possible that you would need to weigh: your chucks, towels, your different peri pads. I know we had different peri pads that were in the vaginal pack kit versus what we gave them postpartum. So those are differences. You need to get dry weights for all of those things. You want to begin after delivery of the baby and prior to the placenta. You can record the amount of fluid in the calibrated drape after the baby is delivered, and subtract any irrigation if the doctor's doing any irrigation or any wiping or spraying of the perineum that's going into the drape itself. You want to calculate that. We found that it was helpful to switch out the drape. You can do that as well. It gets a little bit more expensive, but that you can do it that way as well. You want to record that total volume and then subtract your pre-placental fluid from your post-placental fluid. You want to weigh all of your blood-soaked materials, as I talked about, and then add your volume that's in the drape with your weighed materials. Making note that the fluid that's collected in the drape before or after the delivery of the baby is usually amniotic fluid, urine, feces, any of that kind of stuff. The volume that's in the drape after delivery of the placenta is most representative of blood. And then you want to add all of those weights together and measurements together, and that gives you your QBL. Oh, and just saying, you can use baby scales that are in the room, or you can purchase scales that are on little carts. There's lots of different ways to do that in the room. This is the Creche RRU with a refrigerated drawer that our Sutter Health, we have about 16 hospitals that did obstetrical care in Northern California in our healthcare system. And part of the quality improvement project that Sutter Health took on was to purchase these units for all the hospitals. And so we put in the request on how many we wanted to have. And so they were pretty nifty. And so we standardized each of the drawers and had all the supplies that you would need. The little bigger drawer that's right at kind of towards the top where it says microcool is your refrigerated drawer that you can put your refrigerated medications. And then we had the top little drawer that was pulled out was a locked drawer that we had all of our other medications that didn't need to be refrigerated. We did dry weights cards. We laminated those. We did posters and we hung them everywhere in all the delivery rooms, on sides of the carts. We made badge buddies that had dry weights and information about blood and blood transfusion, things like that. You can also use the whiteboards that are in your room to record those calculations that you might need to make. And then your dry weights, this is a sample of a paper calculator. In looking at, you can plot through some of those amounts as you collect them and plot that, and so that you have an easy checklist sheet that you can use to calculate. If you're on the electronic medical record, we worked on, we had Epic, and so we worked on a calculator that was in the INO flow sheet that we could just plug in the amounts that we collected, and if we did it at different times, and then it carried through to postpartum. So if they continued to weigh and measure blood loss, that it would have a cumulative amount at the bottom. But we imported all the dry weight materials into that, so it would automatically calculate all of that for you. So quantifying blood loss for cesarean delivery, you want to begin when the patient ruptures or after delivery of the baby. The physician will suction and measure, you can measure all the amniotic fluid before the placenta, usually in the suction canisters that you have. Most places that I've worked at have had two containers, and you can switch the containers if you need to. If you just want to do after delivery of the baby, suction all of that in one canister, and then switch to the second canister after the placenta. You want to note any amount of irrigation that you use, and then weighing all your blood soaked materials, and then adding all of that together to get your QBL. Here's another example that from the CMQCC toolkit that looks at having just a checklist worksheet that you can have. You can manually enter these numbers and calculate. And there were the dry weights in grams on the things that they would use in the OR. There's also the lap sponge container or holder. This one happens to have a blue background for it. I've seen some that are clear, but you can, one lap sponge in each holder, and then the little picture to the side there were scales that I bought for our unit that would hang on the pole, and so you would just gather that when it's done. hang it on the scale, get your weight, and then subtract all of the amounts of your dry weights from the sponges and then the counter bag that you used. And then this one is the colorimetrics with the AI. The Triton machine is what I mentioned earlier. They use an extraction technology with color algorithm to calculate the hemoglobin mass. That there's lots of different studies that looked at accuracy. These are listed at the bottom there. It doesn't account for larger materials such as the drapes and sheets, but it does offer the highest degree of accuracy in, how am I doing on time? Offers the highest degree of accuracy in blood loss estimation. So pretty phenomenal little gadget if you just hold the piece of material that you want weighed up next in front of the iPad, and it'll calculate blood loss for you. So I'm looking at quality improvement projects that were in the studies. Laducier and Goldberg in 2019, they changed their practice from EBL to QBL, and they started with vaginal deliveries. They educated all the staff on how to do quantifying blood loss. They replaced all of their drapes with the calibrated ones. They had medical grade scales that were in each room. And then their clinical nurse specialist attended several births to kind of help with the proper technique and help the nurse complete some of that activity or weighing and measuring. They audited and for documentation, they had about 91%, which is good. They did meet some resistance with some of the providers, but who later supported the change as they started to watch that amounts were being recorded, and so they had a more accurate picture of what their blood losses were. Steinberg 2019 study, they targeted L&D nurses and documented and their documentation. They used a scorecard that was blinded, and they posted those that showed feedback. And then they did a run chart that showed any of the progress that they'd made. They compared EBL with QBL volumes and found that they had a significant difference between the mean EBL and the mean QBL for all births without any increase in blood product administration. And then I just wanted to mention that in 2017, I was looking at some of the literature from Sechrist and others that were looking at the CMQCC report. They did a study on looking at 21 nurses and physicians from 6 hospitals in New Jersey and Georgia. And they identified successes that for sustaining QI efforts that and some of the successes that they identified were that they had to have support from administration. Administrators are the ones that buy the equipment for you that you need to have. They buy the training that you need to have. That everyone needed to have positive attitudes. So the more positive you can be and the more cheerleading that you can be, the better efforts for quality improvement you can have. They identified active nurse and physician champions. That's a must. I tell you, I worked on many QI improvement activities or interventions at the hospital that I was working at. Even system-wide hospital initiatives was such a struggle sometimes when we didn't get buy-in from administrators and we didn't get buy-in from the physician groups and nursing too. But it helped when we got a nurse and a physician champion in place at each of the facilities that could help spearhead some of the information that was being talked about at the huddles, talked about at the medical staff meetings, things like that. And then another successor is to have an existing culture of safety. So all of your hospitals should have, or I would hope to have a culture of safety project. We did Team Steps, which is a great program, and working on communication amongst staff, having a shared mental model, things like that, doing call outs. And all of those communication pieces are so important when we're talking about quality improvement, talking about quantifying blood loss and how we communicate that in the delivery rooms, making sure that you're calling out that information loudly enough so that everybody in the room can hear that you're doing okay or you're not doing okay. So the last, just reviewing, we are doing all of this work because of patient safety. We want to make sure that our moms and have healthy outcomes for themselves, not only for themselves, but for their newborns as well. And so this is the way we do it. We quantify blood loss. It's the gold standard for identifying blood loss. Everybody's getting on the bandwagon now, including CMS. Practice, practice, practice. I can say drills and simulations are so eye-opening for people that the light bulbs go off. You learn from each other. Certain nurses may have ways of doing things that are that the newer nurses or even the older nurses hadn't ever thought of, things like that. So practice always. Do it for all deliveries, regardless of type. Regardless of the quickie drive-by that comes in or the long lengthy one. Do it for all deliveries. It should be a nurse-led intervention. It's not always a nurse-led in the OR, and that was a struggle for me to try to change that practice because it was always anesthesia that was responsible for blood loss. But it should be a nurse-led, that she's responsible for looking at the canisters and weighing the materials and calling that information out to the physicians that are in the room. But it should involve all your providers. So the conversation needs to be there. Using the drapes and scales and worksheets and your laminated cards, your badge buddies, any of those kinds of things. And the more you can get out there to the staff. Using the success cards, the information, individual report cards, if you will, on how you document or that you're doing it. Involving your champion nurses and providers will help facilitate that change, and making sure that you have an evidence-based policy and procedure that addresses OB hemorrhage. There's lots of samples out there. CMPCC has one. I've looked at others from other states. There are other toolkits that are out there that are addressing OB hemorrhage that have samples for all of this, and that QBL is done for all deliveries. So that's all I have. There's a few minutes left for questions if you have any, but here's my contact information. I do have a list of references. If you would like them, I can send that to Amy later if there's anybody that would like those. And feel free to send me an email if you have any other questions about anything. I'm happy to help. So that's all I got.
Thank you so much, Dr. Gable. We do have 2 or 3 minutes. If you have any questions, feel free to come off of mute, or if you're not comfortable coming off mute, feel free to type those into the chat. We do have Dr. Kakia said, thank you very much.
Okay.
I think this is a very important topic. It's a very good review for our facilities. And like you said, coming down the turnpike, it's going to be kind of the pay for performance. So, thinking about that ahead of time and getting processes and policies and doing simulations and drills is going to be very, very important for our facilities.
That, yeah, the CMS and involving there's language in there about emergency departments being ready as well, and educating staff and making sure that you're training and having policies and procedures in place for that department, especially in those hospitals that don't have OB services. You still need to have a way to treat those women that come in for an obstetrical emergency for hemorrhage. And so that's
Any
going to affect
words of
those hospitals. Yeah. So
Any words of advice on that, Dr. Gable? I know working on our cardiac initiative, that's been kind of a challenge getting into the EDs, especially those that don't have OB-EDs, but providing basic watch, warning, signs, symptoms to ED providers and staff. So any advice on the work that you've done over time with working with emergency departments would be greatly appreciated.
The project that we did, with Joint Commission, because Joint Commission also has a lot of that language for OB hemorrhage and cardiac or hypertension, and that you involve your emergency departments in that they have training. And so I was lucky enough to have a clinical educator that worked in the ED that was a good friend, and we partnered together and did the dog and pony show kind of thing. We went to all the medical staff meetings, we went to staff meetings, and talked the language and kind of promoted all of that. We made sure that we had equipment in all of the areas that they needed to. And logistically, that's sometimes kind of hard because all of our supply rooms are so full of stuff anyway, so that we had to get creative on where to put things. We had to get blood bank involved with the massive transfusion protocol, because a lot of that work has come out of the emergency department for their massive transfusion. So we had to collaborate together to get that into the OB world. But champion. I can't say enough about it. Getting the right people in the room at the right time. And those with positive attitudes. You can't come into the room and have a negative attitude about anything, because change won't happen. So you pick and choose your team really well, and pick those that have great attitude and that work well together, and that's how you get change happening.
Thank you so much.
You're welcome. Thanks for having me.
Absolutely. So, wonderful presentation. Thank you all for joining us today. Just a reminder that our next maternal webinar will be Tuesday, December the 3rd at 2 p.m. Make plans to join us then, and thank you and have a wonderful rest of your day.
Thank you.